Hello, and thank you for joining us for another episode of Matters of the Heart. This is a program brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. My name is Dr. Srivastava. I'm a cardiologist at Pentucket Medical in Haverhill, and I'm joined today by one of my colleagues, Dr. Seth Bilazarian. And today we're going to talk about cholesterol, but in a slightly different way. We're going to talk about cholesterol and problems with cholesterol in younger folks and the use of medications. Specifically, the type of medications are called statins. Those are some of the most commonly prescribed medications in America. And some of their names, just so the audience is familiar with everything, there's simvastatin, which used to be called Zocor, atorvastatin, which is Lipitor, there's rosuvastatin, which is Crestor, and those are some of the more common cholesterol medication names. So with that, I think I'll just turn it over to Dr. Bilazarian and let him get started on this topic.
Sure. So what I think that we have talked about many times in this program is what evidence there is or what kind of studies have been done and published in medical journals to support the use of different kinds of strategies. We've talked about a variety of things, medicines, angioplasty, bypass surgery, and we try to make decisions based on studies. The second way that doctors sometimes make decisions is based on what some people call consensus guidelines. And really what consensus guidelines are, a bunch of very smart physicians from around the country, sometimes around the world, will sit around the table and try to hammer out best recommendations for treatments of different kind of problems. Particularly in the area of cholesterol, we have this kind of guidelines. It's called the ATP guidelines. It's part of the National Institutes of Health's program to recommend to physicians best ways to treat patients. And you and I have worked with this for many years, trying to make the best decisions for patients. And most of the data, I would say pretty much all of the data, has been generated in people older than age 50. And it's one of those things that if we don't have data for people less than 50, we're really left with two choices. One is, can we try to figure out how to use it even though we don't have all the data and use it for patients less than age 50? Or should we just hold our hands tight and say, let's wait until we have more data? And that's really the question for a variety of things. We're not faced with this problem just with age. We're faced with it with a variety of other issues. There's been criticisms that we don't have good amount of information for certain kinds of groups of people. Like there's not that much information for groups of women. Most of the data has been generated, particularly in the cholesterol area, for men. We also have been criticized for issues about certain racial groups. Most of the data has been generated in patients who are of Caucasian or white background. So that doesn't tie our hands and say, well, we're not going to give this to people who aren't white or who are women or whatnot. So I'm asking today to have a conversation with you about this topic that has been brought up in the literature. Should we be more aggressive about treating people who are having high cholesterol but aren't yet age 50? At what age should we begin to treat people more and more? Now, there is already many people that are younger, even as young as 16 or 18 years old, that are being treated with cholesterol medications at our leading pediatric hospitals here in New England. That would be at the Tufts Medical Center or a children's hospital, that are being treated with statins if they have a particular very high cholesterol problem called familial hypercholesterolemia. These patients have cholesterol numbers not just over 200, but over 3 or sometimes over 400. In those patients, it's felt it's appropriate to start very early with cholesterol medicine. So there is some people that are treating young people with cholesterol, but there are others like us who are practicing in the community trying to make a decision about what would be best to do with a patient who has high cholesterol, not the sky-high cholesterol, but a high cholesterol, and they're age 25 or 35 or 45. And to me, one of the things, and I'd love to have your opinion about this, it just makes no sense to wait till someone's 50.
Right.
Because we see patients, and I just took care of a patient recently who's a heart attack patient who's only 43. Why would I wait? Of course, now I'm treating him at age 43 because he already had a heart attack. Right. But wouldn't it make sense to treat some patients before?
Well, I think you could also talk about the fact that plaque is being laid down in your arteries at a very young age. It doesn't just start happening at age 50. 20s or what have you. And
what evidence do you know about that?
What from there's certainly a lot of autopsy studies, animal studies, things like that to show that there is certainly plaque being laid down in your arteries at a young age.
Sure.
What evidence do I have that we should give a statin to those people?
No, I was asking just you to review that data that we all know that we talk about with our patients sometimes that it's also often highlighted that the regrettable outcome of war, of course, is the death of young men.
Right.
And oftentimes these autopsies from young men who have died in the military has shown plaquing in arteries.
Right.
So we sometimes think of heart disease as a disease of old men, but I just want to emphasize what you just said, that we already see little what's called lipid or fatty streaks, little yellow streaks in the walls of the artery in 18-year-old men.
Right. So that would, I guess, then tilt the argument to perhaps consider treating these people more aggressively at a younger age.
Right.
So is there any data out there about this? Are there any studies or anything?
Well, there isn't any studies, again, that are the large kind of studies that doctors really love. Doctors call these RCTs, or randomized controlled trials, where you give half of the patients a drug and half of the patients a placebo pill, and you say which group did better. Now, we would love to have a study that looked at 25 to 45-year-olds and compare those two groups, but we really don't have that data. So we really have to rely on using information like the information we just discussed from population studies to say that we know that this process starts early. We know that it does affect some people well before they're 50. Are there patient populations or circumstances in which it would be sensible to treat people? And I guess that's the question.
Let me ask you it this way. What are the barriers to treatment? Why wouldn't we treat? So let's say 38, 39, 40-year-old gentleman comes in with very high cholesterol, tries to do some lifestyle changes and exercise more, and maybe has a strong family history of heart disease as well. And why wouldn't we treat that person?
Well, I guess I may have misled the conversation by saying it. Your question requires some clarification. There are patients that we are recommended to treat. So I wanted to go back to those consensus guidelines.
Okay, sure.
So we didn't have any kind of, we don't have any kind of data for that patient.
Right.
So I can't point to a trial and say, look, there's a medical study that says patients of your age, your condition are benefiting by getting a cholesterol medicine. Mm-hmm. I can't say that. But we are encouraged to use certain risk scores. There's a risk score called the Framingham Risk Score. Patients can find it on the internet. They enter their age, their cholesterol, their blood pressure. And there's another one called the Reynolds Risk Score, which is more popular, which has those features, the age, the blood pressure, the cholesterol, but also family history, which is not in the Framingham Risk Score, and another test called the C-reactive protein, which we've talked about previously. And it adds that all up, and it tells us what the patient's 10-year risk of having a heart attack or a stroke or other vascular problem is. And we've been taught from this consensus guidelines that we should treat someone if their risk of having a heart attack is over 20% per year.
Or for the 10-year period?
For the 10-year period. So if over 10 years your risk is 20% or greater, we are encouraged, should treat those patients with cholesterol. So another way to think about that is instead of 20% over 10 years, you can think about it as 2% per year for 10 years. Right. If someone has a risk that's less than 10% over 10 years or 1% per year, those patients are considered low risk, and we're strongly encouraged not to treat those patients. And what I'm really talking about, and I think that you are as well, is what do you do with those patients that are not in the highest risk but are in that medium risk? Do we feel comfortable just keeping our hands off in those patients that are in the 10 to 20% risk? So a patient saying that patient has a 1 to 2% risk every year of having a heart attack, is it justified to treat those patients? And there's been a lot of people who've come up with ideas, but we don't have any strong, definite way to go. We don't yet have a strong way we should treat these patients. But just to summarize some of them, you've done an excellent summary of this problem called metabolic syndrome. And it's said that if someone has metabolic syndrome and they're in that intermediate range, they should be treated with cholesterol medicine, as an example. There's another problem. There's another feature I mentioned called the C-reactive protein. If that's high, some people say that those patients should also be treated with these cholesterol-type medicines called statins.
And what are some of, there seems to be some push to not treat these people because they're young and have the perception of being otherwise healthy. What are the reasons not to treat? Is it concern about long-term side effects from medicine? Is it cost? Is it whatever?
You can keep going, and I'll keep saying yes. Because I would say yes, because we don't know about the long-term risk.
Maybe I'll just interrupt you real quick, just to review for the audience. What are the risks of taking these statin medicines, short and long-term?
Well, I would say, I don't know, I would love to have your opinion about this, but I have to say, I don't think there's many short-term risks.
I tell people that I think it is one of the best bangs for your buck as far as one of the safest medicines out there.
Right. Well, let's talk about the short-term risk. Yeah. So there is a short-term risk that some people always bring up, that people hear about when they go to the hairdresser or talk to the barber, and that's this risk of liver issues. If you take these medicines, they can sometimes mess up the blood test of the liver called the liver enzymes. But 99.999% of the time, if you do have that liver abnormality, if we stop the cholesterol medicine, your liver tests come back to normal. So it's not an irreversible problem, it's a reversible problem. So is that really even a problem? If you can take something and your blood test gets messed up, you stop it, it goes away. So that's one risk, but I wouldn't even really call it a risk. The biggest risk that I think our patients really struggle with is a real one, and that's muscle aches. Some patients have really serious muscle aches, they really suffer with it, and they can't even do their daily life. So that's no bargain to take something that might prevent a heart attack or stroke 3, 5, 7, 10 years down the road if you're miserable every day. So I think that would be the biggest risk I would mention.
I agree with you about that being the biggest risk, but I also think we sometimes attribute symptoms to the statin that really should not be attributable to the statin.
Okay.
Sometimes, oh, I was walking and my left knee started to hurt a little bit. It's probably not from the statin. It's probably arthritis or something. And so I think sometimes and this is maybe a little bit of an editorialization, that maybe we sometimes, not you specifically, but we in general, don't push enough with using these medicines, which have been proven to really save lives and be good medicines.
So to get back on the original question that you asked was, what is the reason not to use this in young people? I think you mentioned long-term safety. These drugs have been around for quite a long time. They have been around since before 1990, so they've been around for more than 20 years. So it's not like these are brand new medications. We've had a long experience with them. But is it long enough? To put someone on at age 30, we're talking about potentially being on it for 40 or 50 years. Right. So that's a question that we don't have answered.
Do we know of any real significant long-term side effects from the medication?
Well, only out to the 20, 25-year period, and we don't. We don't. So then the second question you asked was also a good one, is cost a reason? And I think that's a really good question, but the reason why I think that this topic for us to discuss is timely is we now have there are actually 3 available generic statin medications. And these medications can be had at any pharmacy without even an insurance plan for $10 for 3 months. So that's $40 for a year for these medications. So is $40 for a year? Now, I am not an epidemiologist, an expert in public health policy, but it seems like it's getting pretty close to a low enough cost that it might be justifiable for a large number of patients to go on it. Of course, if it was appropriate. We wouldn't use it if not appropriate. But is $40 a year a justifiable expense to prevent the expense of the treatment for heart attacks and strokes? The cost to our society of disability, the loss of a breadwinner who has a heart attack or stroke. So for all these reasons, I think that cost has always been an issue, but should really maybe be taken off the table now because we're getting more and more generically available medicines. Another very potent generic statin is due to come off and become generic in the next couple of years. Lipitor will actually be generic. So it's really amazing what opportunities we'll have in terms of cost. So the focus again on those harms, I think that's the biggest concern, is the unknown long-term harm risk.
So you mentioned these consensus guidelines or consensus recommendations. Maybe this is a good time to start. Just tell us what those are. Maybe you can review some of the recommendations.
Well, I think that the only consensus guidelines I can mention is these ATP guidelines that I summarize, where if you have a risk over 20% for 10 years or 2% per year, you should have your cholesterol treated if your cholesterol is high. Mm-hmm. And that in this borderline range, it's really sort of an issue we can go back and forth about whether you should be treated. Now, there are certain parameters in the cholesterol. We're talking generally about cholesterol, but I think our audience that has been faithful to our program knows about the different parameters of cholesterol, the good cholesterol, or HDL, the bad cholesterol, LDL, and the triglycerides that help clarify risks in addition to the total cholesterol. So we may get further evidence from those numbers that help clarify that in-between range patient, the patient who's not high risk, not low risk, but if they have certain numbers that are out of whack, the good cholesterol is low, the triglycerides are out of control, we may favor earlier treatment. But I'm really trying to give us I'm trying to have a conversation with you about the much harder patient population who is clearly not in a good range, but may have risks like you described, say a family history or is overweight.
Well, let's just use an example. So a 35-year-old male has no history of...
Well, let me just even make it... Let's not even go 35. Let's say 40.
Okay.
Let's say 40.
40-year-old male has no other medical problems, healthy, but is noted to have high cholesterol on a recent blood test.
Right.
But also has a family history. His dad had a heart attack in his 50s, for example.
Okay.
What do we do with that person?
Well, let's talk about it. So the patient can get a medicine that I just described for $40 for a year. So cost, and we have benefits of being in the wealthiest society on the planet. $40 a year seems like that should not be prohibitive for most patients. It's much less than cable TV for a month for a year's supply of this medication. So I think cost is something that we should almost take off. I don't want to be insensitive to cost with eye patients, but I think that that's something. So let's focus on really, the pluses and minuses. The patient would have to know that there's a potential that they might get these liver issues that would be reversible and we could check and stop. They might get some muscle aches, which would go away if we stopped it. There has been concerns that has been brought up about other issues. There's always been concerns that have been brought up in the internet about other side effects of statin, which doctors, I think, really don't believe. Like, could it have an impact on brain function? Some people have said statins are safer for brain function. It prevents dementia. Other people have said maybe it causes it. There's been issues raised about potential cancer risk. I think most doctors don't believe that risk either. I guess the compelling thing that I tell my patients sometimes is almost every cardiologist that you've ever seen is probably on a statin therapy. So sort of speaking for, what do cardiologists believe and do for themselves. Right. But to answer your question, if the patient has an LDL or bad cholesterol and it's in the range of, say, 145, our old goal was 130 for everybody. Our new goal seems to be 100 for everybody. This patient's quite far away from that at 145 to get down to 100. That patient, after a good trial of diet and exercise, weight loss, is likely to get only about 10% lowering of that cholesterol. So maybe gets from 145 down to 130. We're now left saying, we really think that we can lower your chance of having a heart attack like your dad did by about 35%. Now, it's not 100%. We'd love to be able to say we can prevent your heart attack, but a 35% lowering, is that good enough? Let me kick it back to you.
Yeah, I think I think that's a good number. Lowering it 35% more is that's a pretty good therapy. Okay. That we don't often have that type of success with a therapy.
Now, one thing I will say that I think is interesting for me just to think about as someone who is inclined to be enthusiastic and aggressive in this regard, I would say that some people have said this 35% number isn't good enough to use in younger patients, but I could actually make a counter argument that would say that the 35% might be even better in younger patients. And the reason for that is if you're 50 or 60 in the trials and you start the cholesterol medicine, you already have plaque in your artery. You already have a 50 or 60 or 70% blockage, and we're trying to prevent it from getting worse. Whereas if you have just the beginning of a plaque, a 10 or 20% plaque, we might be able to stop that or maybe even get it to get better. It's called regression if we treat it earlier and longer. We may be starting too late. So some of the evidence that we're using for not treating patients earlier may actually be able to be turned on its head, and we might be able to say, look, we really should do better by treating you earlier and preventing this over a longer period of time. I don't have any evidence for this, but what I tell patients, the way I like to think about this, is that the arteries are being bathed in fat. That's what the cholesterol is. And every day in your 20s and your 30s and your 40s that you're bathing in fat, a little bit of it's getting deposited in the walls of the artery. So if we could start earlier and knock your cholesterol down 30 or 40%, we may, over the long run, have a substantially better risk in preventing the long-term risk of heart attacks and strokes, rather than waiting for a lot of it to build up and then starting in the 50s and 60s.
Right. It somewhat leads me to my next question or thought process here, was about the really young people. We see every day in the news or read about it with how the obesity epidemic's taking off and is now really affecting children. And you're seeing more and more teenagers who are morbidly obese, have high blood pressure, diabetes, high cholesterol. And I'm not talking about that rare familial hypercholesterolemia condition you're talking about. What about these folks? What about these kids? 18-year-olds or 17-year-olds?
Well, I guess some of the things you said, I know you know, but I want to make sure that we don't mislead the audience. So you said a young person with diabetes. Give me your clarification. Help our.
All right. So diabetes is a different category unto himself.
So if a young person had diabetes, they need to be on cholesterol medicine. Right. That's it. We're done. You have to be on cholesterol medicine if you have diabetes. That's the current recommendation.
Right. But see, but then you're almost stating or concluding that the long-term risk doesn't exist. In other words, you're willing to give it to this person because you deem them to be at risk, and so you're not really concerned about any potential long-term complication of the medication.
No, that's not the way I would think of it. I think what people are saying is that once you have diabetes, your risk is so high
Right.
that therefore whatever potential risks that are unknown
warranted.
are outweighed by the benefit. That's the way I
So let's
think.
just take away that diagnosis of diabetes.
Okay.
An 18-year-old kid who's morbidly obese, has high blood pressure, has high cholesterol. What do you do?
Well, that is, that's really, I think that we're both inclined to want that patient to do some really important lifestyle changes that might make a difference, but we know that they fall short.
Right.
And it's a great conversation again, like when do you have done a great program on high blood pressure, talked about risk factor strategies that aren't medicine,
Right.
but how long do you persist with that? How long can you just keep waiting and waiting? So this 18-year-old, he comes in, he's 19, he's still overweight, and you're still encouraging him to diet and exercise. He's 20, he's 21. How long do you wait? Like, when do you say, like, if you don't, when do you draw the line in the sand to say, we now are so worried about you that we really want to do a better job in terms of risk factor modification to accept it? I don't have an answer, and that's why I'm talking about this. I rely on you for these answers.
No, I don't have the magic answer. I mean, it's obviously like anything, it's a case-by-case thing, and you have to do what you think is best. But it's becoming a bigger problem, I think, as far as the youth or the young patient with all these conditions that I think 10, 15 years ago, you probably weren't faced with it that much.
Right. I guess I would say one thing to clarify my position on this is I would be inclined to treat that patient.
Sure.
But one thing that I want to emphasize that I know you have seen as well is one bad thing that happens with these medications is that the numbers get very good. And what I mean by that is that when numbers get very good, patients sometimes stop making efforts in other areas. So we could give that 18-year-old a cholesterol medicine, and his cholesterol numbers would go from bad to probably excellent. But we know that he still has the risks of being overweight, not exercising, high blood pressure that he would benefit by. And does he go ahead and go to McDonald's and not exercise because now he's on a cholesterol medicine?
Right.
I don't know the answer to that. And that is probably, for me, the biggest reason not to treat young adults.
To still have the carrot out there
Exactly.
as a motivation. Okay.
Yes.
Yeah. And I think you do have a little bit of time, certainly, to push and encourage. Now, there's been a lot of press in the last couple of years about the major pediatric societies and what their statement what have their statements been on this?
I don't follow the pediatric literature, but I know that in our Heart Association literature there is evidence about not evidence, but guideline recommendations or scientific advisories for treatment of patients with certain conditions like familial hypercholesterolemia and with diabetes.
I think a lot of the pediatric societies have become much more liberal in their recommending of statin use in young patients, excluding that condition, for all the reasons we've been talking about today, to get on top of things. And there's no data about this. Is just like what you talked about, consensus opinion. Right. A room full of experts who sit around and talk about it and weigh the pros and cons and come up with it, and that's all we have.
And their guidelines and recommendations are, of course, excellent for an average or in general, but we're left trying to make the best decision using their general recommendations for our specific patient, which can be very problematic, and it really is troubling for us to try to do the best thing for what we can for patients. But to use the pediatric example, I don't think the pediatricians are any more behind this than we have been. We've been behind sort of this understanding of the rising problem with obesity and exercise and the really overwhelming burden it's placing on us in terms of healthcare consequences, but also healthcare costs.
Do you know of any other studies going on right now, or any studies going on right now? I shouldn't say any other studies, but do you know of any studies going on right now looking at this prospectively?
I know of none, and that's really what we're left with as a problem. I think most physicians know, but for our audience, I would remind them that most studies like this are really funded by industry, by the companies that make these drugs, and they're often criticized in our society by the press or by others, as they're sort of bad people, these people who make these drugs. But they have provided a very useful thing, number one, giving us drugs as options, but also funding the research to get us these answers. And I don't know of a reason why they would be motivated to spend tens of millions of dollars to do a study on younger patients. No. So I don't know where that will come from unless we have governmental support to try to answer these questions from National Institutes of Health. I think that's the only place it's likely to come from, but I know of no study that's going on in that regard.
Right. Okay. From my standpoint, I think that wraps up a lot of the discussion. Is there anything else you wanted to touch on with regards to this topic at all? Or? No,
I think my main issue, I think that we've had a really enjoyable conversation with, and I wanted to have this conversation in front of the audience so they can see how doctors really struggle with trying to make the best decisions for patients, sometimes not having the answer. I mean, the easy things are the easy things. I think that the value that we bring as physicians, trying to be up on the literature and synthesizing the literature and the patient's situation to try to make the best decision for the patient, is really highlighted by a problem like this, where we don't have an easy answer. Like, we know that every patient, after they get a stent, should be on Plavix. That's easy. But how about the ones that are harder, like this, where we really might be able to make really important impact on patients? I think the biggest problem here with this particular problem is it's a prevention strategy. And prevention has many good things, but it also can be very difficult to prove benefit. And also, patients are often very hesitant to accept preventative strategies.
If you, at age 33, 34, you feel great, you're doing fine, you have no problems with that, to be told that for every day for the rest of your life you're taking a pill, it's a tough pill to swallow, so to speak, that a lot of people have a hard time with. I understand that, certainly. So to sort of summarize here, I think we know without any doubt that this class of medications, the statin medications, have been shown to have very good effect as far as reducing heart attack, stroke, in patients who are older, and such. But where the gray area is really in the younger patients, where we don't have a lot of data, and that we, I think, as we exhibited today, often struggle with these decisions. And I think in the end, you have to do what you think is best. That you synthesize it, just like you said, you synthesize everything and come up with a decision that way. That there's no thing to look up on the computer that tells you what to do.
Right. As you were speaking, though, I did want to make the comment that we weren't ever saying that young adults that don't already have diabetes, don't already have a vascular problem like a heart attack or stroke. We're not talking about those patients.
No, right.
We're 100% convinced they have to be on these medicines. We were more talking about patients who don't have a problem, so-called primary prevention patients.
Right. All right, well, with that, we are certainly running out of time, but thank you for this nice review about a problem I think we're facing more and more of, unfortunately, and that is the problem of high cholesterol in younger and younger people, and what we do with it and how we struggle with that decision. So thank you very much. This was Dr. Seth Bilazarian from Pentucket Medical Cardiology. I'm Dr. Sunny Srivastava. This show is brought to you by Haverhill Community Television and Pentucket Medical Cardiology. Thank you for joining us, and we'll see you next time.